So we are talking about the adult high-risk vaccination. We know, and actually in most countries, in West Europe, in the States, the adult high-risk groups are included in the national immunization program. The major issue for countries like Jordan is that we have limited resources. يعني الشباب الله يعطيهم العافية, they want to do new vaccine, so always they try to get more budget for it. I think it's a process of partnership between the private sector, health insurance companies, and also between the Minister of Health. Also that I believe personally, for example, you have a patient with diabetes, his vaccination should be part of his management protocol. So the budget should not be always command fee على vaccination program. But we should have هلا في عنا electronic database, في عنا حكيم in Jordan. So it's good actually to have the when you have someone his age, for example, 65, 70, you'll be alert that this person needs this vaccine and that vaccine. So I think we should have work together with Professor Weil, Dr. Kamil, to have at least initially a draft for the national adult immunization and one for the high-risk groups. And we need them to work with other different stakeholders, with medical societies, with different hospitals on the implementation for the for different patient groups. It's actually the adult vaccination is not just a local issue or regional issue. It's a global issue that we, as we are protecting our kids, our community through the national immunization programs for kids, we have also focused on the different groups. You can see here about the seasonal flu vaccination for children, also look for adults, and you can see the difference in the uptake, and we need to work on that. There is a global issue for under-evaluation of the impact of the adult immunization from healthcare providers, from the community, from different stakeholders, and always we have also the budget impact. You can see there are different vaccines for the adults, including shingles, hepatitis B, whooping cough, mumps, etc. So we should have, we'll discuss briefly now how we can assist the vaccination for adults. Vaccine preventable disease can, for example, in the States only can save 10 billion from different direct and indirect medical costs. What do you mean by direct and indirect medical costs? When you have certain infections, for example, pregnant women, elderly, his age is 70, he got influenza virus infection. They'll be admitted to the hospital. They will visit emergency. They will visit outpatients. These direct costs from the complication rate, from the admission rate, from the secondary infections, from the work loss, like especially for those below the age who are still working, all this should be calculated. And with this will show the cost effectiveness of the adult vaccination. Who can have the vaccines? We have different groups who need, according to their medical illness, according to immunity, those with sickle, with COPD, bronchial asthma, solid organ transplantation, congenital or acquired immunity, cochlear implants, metabolic disorders, diabetes. I think in Jordan we are focusing on only selective patients for the strep pneumonia for adults. The other groups are not really taking that attention. So we need to check that we have the vaccination for these groups. I can show you this strep pneumonia. Dr. Adil Saih, she shared with us a great news this morning about PCV13. If you look at the patient with COPD, these patients, they have recurrent admissions per year. Kids, and I'm graduate from Just, when I was student in the 5th year, 6th year, we used to have a high incidence of, we have a high rate, actual incidence rate of cystic fibrosis in north of Jordan. These patients usually they have admission 5, 6, 7 times per year from different infections, from flu, from strep pneumonia. If these kids are given the vaccine, it will prevent major burden on the healthcare sector. The same for asthmatic patients, for smokers, for chronic heart disease, diabetes, etc. You can see the impact of just giving a COPD, strep pneumonitis, the incidence is very high for those with COPD. This is why we have to do the vaccine for them. The Minister of Health are studying now the varicella vaccine. Actually, in the UK, hepatitis B varicella, they were given for high-risk groups and others before they have it in the national immunization program. Varicella zoster shingles, the incidence is very high after the age of 50. So if we have a mature adult vaccination program, I would encourage my colleagues to start with the age of 50, but because we don't have that, so we are going to start with the national immunization within the first 2 years of life. But at the stage when we have an active vaccination program for adults, we should look for shingles and you can see the high incidence for them. So we have to look at the different vaccines, varicella, BCV, shingles, zoster, and all these vaccines. During pregnancy, we have to look at the different infections actually, because they change the immunity. The severity is much higher during pregnancy. This is why we have to look at the vaccination. And you can see the uptake is not just a regional issue, it's a global one. The uptake of vaccines, even in the country for adults, is still a global issue. It's not just a local one. Scale. How is the health condition? Is this subject is healthy? They have diabetes, COPD, bronchial asthma. They have acquired immune deficiency, congenital immune deficiency. Then we look at the age, the lifestyle, and occupation. And then we act accordingly, okay? Lifestyle, we look at the illicit drug, homosexual, travel history, foreign-born, international travelers. Each group, they have certain vaccines for them. Healthcare workers, we have also considered vaccines for them, and we have to encourage that. And I would like to thank Dr. Kamil Roussel. Actually, he's keeping an eye about the seroprevalence. Recently, he shared with me a document from medical students at Jordan University. They received the vaccine in 1995 or something. Now they are fourth-year students, but the seroprevalence was not reaching immunity level, so they need a booster dose. So we are trying to do the same for measles, mumps, rubella, and also we are waiting a feedback from potential sponsor for that, because we need to look also about the long-term impact of these vaccines, measles, mumps, measles and rubella, especially for females, and we have to look for hepatitis B for high-risk groups. We need, the good thing actually about what is done now is that we are not just resting that, okay, since 1995 we have hepatitis B, so we have to rest assured. No, we are not trying to look at the long-term impact of these vaccines and whether a booster dose is needed and at what age this booster dose is needed. We need to look at the different age occupational groups, and this is based on that. So we have different recommendations. It's for the different age groups and different patient groups. We have to have certain vaccines. We have to look for the age, and we have to look also for these different vaccines. So unfortunately, in the whole MENA region until now, we don't have the adult high-risk group vaccination integrated within the National Immunization Program. There's different issues there. We need to sit some time to brainstorm how we can do that. The major limitation, actually, I can see, Dr. Kamil, do you agree on that? The budget constraints, the major limiting factor, and also to ensure the high uptake. We don't need to get, for example, 203 or 3,000 doses of varicella for adults, and then the uptake is very small. We have to look for different factors from the uptake, compliance with these vaccines, and also the budget. I'll skip these ones for the sake of time. And as we said, we have to look for different vaccines according to the different factors. There are different barriers for the uptake of adult vaccines: lack of knowledge, lack of support from healthcare professionals, limited access to preventive services. We have long lists of barriers, but we have to assess the barriers in each country.